You've had these patients who are waiting weeks and weeks to get a result, and hopefully there's sufficient sample to get a result from DNA sequencing, and then you can choose their therapy. With a pathology AI-based test, you get those results right away.
Welcome to Target Cancer Podcast. My name is Dr. Sanjay Juneja. I'm a hematologist, medical oncologist, also known as the OncDoc on social and news media. And you're listening to Target Cancer Podcast, where we want to talk about the things that I believe and that we believe as a community are going to be things of tomorrow, but at the same time kind of exist today. And that's why we want to make sure that people that have problems today at least know about these things and, if appropriate, can seek them out. Now, today, I want to talk about something that I am going to intro because I say it to all my patients, and I worry that people are going to say, well, Sanjay, why are you saying it like that? And I'm saying it like that because it's the truth. And that has to do, in one context, with adjuvant therapy. So when we give therapy after a curative setting, and I have these discussions about the toxicities of chemo or hormone deprivation, and give them an idea of how much it improves the chances of them not having a recurrence or living longer, the important thing to note, and that I'm honest with my patients about, is we can do this, but realize if, say, 30 or 40% of people would recur, and this reduces it by, I'm making numbers up, 15%. I have to tell them, if 30% recur, that means 70%, 70 out of 100 that heed the advice get something for no reason, right? If 70% would recur without, 70% wouldn't recur without adjuvant therapy. You're reducing 30% to something like 18% with adjuvant therapy. In my example, means most people didn't need it, but you don't know who it is. So something we have not addressed directly and that we've done peripherally is, one day, I believe with AI, and a lot of us do, we will have a better idea of who fits into what buckets. That is why I'm extremely excited today to have Dr. Tim Showalter, who is focused on just that. Can we do things better than these broad, obtuse buckets of recommendations that have kind of labile, wide range percentage chances of working and necessary and not? And the reason being because of the unquestionable morbidity and quality of life and risks of therapies that occur when you have a broad bucket and can't hone in on the benefits. So I'm going to stop talking now because there's a lot to share. I think it's extremely novel, the things that Tim is looking into. He's had an MD training. He's been at the University of Virginia. He's been a professor. He has an MPH. And now he is doing something very elite and novel. So, Tim, we are so grateful and excited to have you.
Well, Sanjay, thanks so much. It's wonderful for me to have a chance to join you. And I think you really, that overview you provided really summarizes a lot of what drives me and what drives Artera, the company that I'm chief medical officer for, to really make an impact for patients. And so, yeah, I struggle with many of these same things. I think I shared with you that I'm a radiation oncologist by background, so obviously slightly adjacent specialty to your own. And certainly always wrestle with that concept of making sure that we're matching the right therapy to the right patient and not over or under treating. So it's a real important area to work on.
Yeah, there's this concept I've been introduced to over the last year or two about moral injury, right? And its contribution from the provider standpoint on burnout. So the burnout is like death by 1,000 paper cuts, bureaucracy, red tape, blah, 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 sure. But also just simply how comfortable are you going to bed at night because of something somebody's electing for or not, and where maybe deeply it may or may not even be applicable, what they're going to put themselves through. I personally think one of those things, and I think data has started to come out, especially when it comes to women, or female gender, because I think, we've been a little chauvinistic in decades ago. And again, I'm saying you share that opinion, but several do. And we went into this total thing of hormone blockade everything, put them into menopause. But on the flip side, with men also, it's like the threshold was low because the goal was just absolute maximum chance of survival and disease-free, intervals or recurrence-free intervals. And on the male side, depriving testosterone to absolutely low levels has a huge list of quality of life issues, everything from obviously sexual health and interest to self-image to gynecomastia to just organic biochemical depression. And we, unfortunately, today in a stage 4 setting, for the most part, say you will forever have no more testosterone circulating. Like that's pretty much the recommendation or consensus. But there is a setting now that dials the moral injury aspect a little higher. And it's not just unique to prostate cancer. It's a lot where here's a couple of risk factors in kind of an obtuse, gross way that says, consider doing something to this person without really knowing, because they're on the cusp. The consequences in prostate cancer is really 1 to 3, if not longer, years of cutting off testosterone cold, but not knowing if it actually makes a difference in the chance of them having a progression of their cancer or recurrence. And I know this is something of interest of yours, and I'd love to learn why. What made you think, and you have this interesting diagram with what you're involved in that popped up on my LinkedIn, and I was like, this is incredible. I was like, this is the number of years past, and that split of what a difference did or didn't make to incur near complete deprivation of testosterone. I'm like, that's huge. And that's why, part of the reason we're on this call. So did it start all with the prostate and hormone deprivation? Was it adjuvant in general or some precision experience that you had that made you do these things? And how did you end up going prostate route, I think, primarily from what I can tell?
Well, you're raising great points, and these are all, there's so much we can go into. So I'm a radiation oncologist first and foremost. I still see patients 1 day a week at the University of Virginia. And a lot of the issues you're talking about with respect to thinking about how hormone therapy impacts, male gender identity, energy level, concern for hot flashes, weight gain, how that impacts, longevity considerations and sense of vitality as men enter their 70s and 80s. These are the sorts of things we wrestle with in clinic. And so, I'll tell you a little bit about how I got involved in Artera and sort of what that journey was like for me. I've always been a very patient-centered physician. So, I've spent more than a decade in full-time clinical practice, both at Thomas Jefferson University, where I got my start, and then for the past more than a decade at the University of Virginia. I have always focused on GYN and genitourinary cancers. And in that experience, there's a lot of really nuanced examples of risk-based treatment decisions and trying to get the personalized information that a given patient that you're in the room with really wants, and to understand what are their values, like what are the side effects that really matter most to them, and how do you help that person? And to your point earlier about losing sleep over trying to make the right decision, I think, sometimes after clinic, I'm losing sleep the night afterwards when I know someone's making a choice. And likewise, I'm sure that the guy that I talked to about prostate cancer in my clinic is having the same experience. And going back about 3 years ago, I was contacted by the co-founders of Artera, one of whom is Felix Feng, who's a very successful translational researcher and radiation oncologist at UCSF, about this research project that they had. And what they had developed was essentially a digital pathology AI tool that could provide these very personalized insights and risk stratification assessments in real time to help patients make a better decision. And when I got a better sense of what the mission was and how you could then translate that into breast cancer to carry through with your example for endocrine therapy for breast cancer and any other solid tumor, it really inspired me to think this is something that really connected with what I've been trying to provide to my patients, but without the right tools. And so it's really exciting to be part of this next generation in medicine. We're going to have, much greater risk stratification and therapy personalization tools available for patients.
We pardon this interruption real quick. If you're enjoying this podcast or find it valuable for what we discuss and the education and how people see and think about cancer in general, we would very much appreciate a like, subscribe, and especially a share so we can bring that information as maximally and broadly as possible. Thank you so much for listening. If I didn't make it clear and you have the same issue, there are guidelines that we have to that are very just clear, algorithmic, I can't call it binary, but maybe a couple of variables. And more or less, I'll say you should offer this, right? to the patient. Even if, some chemotherapy is adjuvant in certain breast cancer settings are like 8% chance, colorectal is like 15. It's not crazy. And those settings are where most people would not recur if you did nothing, right? They wouldn't recur if you did nothing else, they wouldn't recur in some of the stage 2s and stuff where we're still giving things that inflict problems. And that's where the pain points come in, and where this gray zone of sometimes doctors will say, well, so you decide what you want to do, which I think is insane and extremely unfair to a patient that's not medical. Insane. But at the same time, if you incur it, you may have to go against the guidelines because you end up saying the behavior, based on the behavior of your tumor, from what I can tell of your tumor. When we use that statement, there are all these things that can be distilled in granular. How much it proliferates, how much it's differentiated, what was the interval of something that was pretty reassuring you didn't have this and you do now, right? These things that we can't fully computationally analyze, which is why I'm a big believer in AI, or have a lot of faith, because I think they can. And all the things that my experience says, I don't like the way it behaves, that is not in the guidelines. So what you all did was, okay, let's take that. Like, we know that there's observations that we can't necessarily write on paper as not a guideline. And how can we have a true way of saying, hey, you may be offered this, in an obtuse way, but let's really kind of refine it down and see, is incurring that beneficial for you specifically based on certain parameters? And before we get into that, and that, if I understand it correctly, is that 1 to 3 years of adjuvant testosterone deprivation going to make a difference that's occurring, like something more analytical? Now, when I use the word behavior, that's on properties that, again, are secondhand. You glossed over something that has gripped me since I saw it. And you were talking about this digital way of analyzing the actual tissue, specific cancer to that person, and analyzing it without having to retrieve the sample. And anyone that's in oncology can appreciate, and most people that aren't cannot, the frustration of having a tissue sample that's insufficient or exhausted. Because another moral injury, do I delay everything to try to go get you back to the urologist or back to the surgeon, get the biopsy, get the results, get you back in clinic, do the order again, and in that time let the tumor grow, or possible tumor in an adjuvant setting? Or do I go ahead and proceed and just say we couldn't get it? You said, we're going to take that one thing away from you. The company that you believe in are doing this for patients and doctors. And you did it in some digital manner where you can actually assess the architecture of the slide and not need the tissue yourself, and use some fancy magic stuff, and all your schooling and everything to basically ascertain those same behavior features that I'm talking about and analyze what is relevant and not in helping guide that decision-making. Is that somewhat accurate? And because it's mind-blowing.
Yeah. So, Sanjay, it is mind-blowing to me as well. I still feel that, when I joined Artera, now it's over 100 people at the company. But when I joined Artera, what really blew my mind is that, with computer vision AI, the research and development team is able to take digitized whole slide images. So basically scanning the biopsy or tumor resection slide that's obtained for every patient who's diagnosed with cancer, turning that into a high resolution digital file. And then computer vision AI can then go through and analyze, breaks that essentially down into tissue patches and pixels and better understands that. And if you know what the clinical outcomes are for that research cohort training set, you can leverage that technology to build AI-based tools that can identify later on for patients who are, in your clinic receiving care, what their probability of recurrence is and what their likelihood of benefit is. So, we all know there's like science of medicine, there's art of medicine. Well, we're not with cancer, precision medicine AI taking away the art of medicine. That's still there. But I think the science we're definitely building upon. And so we're able to work with biopsy slides for solid tumors. And in this case, we have a test that's available and already out helping prostate cancer patients. And we're able to, scan the slide. We don't destroy any tissue. We depend upon a small amount of tissue imaged on the slide. And then we can return results back within a day or two of receiving them in our lab. And so if you've had these patients who are waiting weeks and weeks to get a result. And, hopefully there's sufficient sample to get a result from DNA sequencing, and then you can choose their therapy. With a pathology AI-based test, like the sort of technology we work with, you get those results right away. And so it really transforms that decision-making process and makes it much more feasible to offer precision medicine and personalized therapy to support individualized decisions in real time in ways that really, reduce anxiety, better optimize therapy, avoid overtreating patients. So that's what's really exciting about it.
I mean, it's incredible. And in my theoretical opinion, the multiplication, tumor growth, heterogeneity, escape mechanisms that happen de novo with replication, time is, I don't mean this to scare anyone, if listening, but you go 3 months, you're going to have a more variegated or heterogeneous spectrum of tumor types within that certain cancer, that are either persistent or don't respond and everything else responds. The variability that goes up with time. And so you're using something to also reduce and make something actionable and cytoreductive, meaning like reducing all the tumor if it's a shotgun approach with chemotherapy sooner. And that's huge. So pardon my ignorance, but because the depths of AI is limitless, at least for me. But when you're looking at that tissue, and for anyone listening, generally you have molecular properties, which are the coding and the way to say, hey, this is something that I need you to make, like as a protein or as a tool or as whatever. And then you have histopath, more protein-based, post-molecular reading, then synthesizing, properties to the tumor. Is your digital computer science AI, fancy term that you use that I will one day learn, looking at actual molecular properties, obviously not directly, but is it indirectly looking at possibly some of those biomarkers or proteins, and then also having the depth of understanding of knowing what that likely means as far as a molecular property to that tissue?
You're hitting on a fascinating topic, and let me preface. I can give you some insights that we do know. We don't know everything, and we're uncovering more. But just to give your listeners a foundation for what we're dealing with. So we have one example test that's sort of a prototype for our type of technology, which is called the Artera AI prostate test, and it's available for men with localized prostate cancer. And in that sort of workflow, we take a standard H&E stain biopsy slide, and these are the sort of normal specimens. It gets scanned by a whole slide imager in the digital pathology lab, and then our cloud-based portal will be the entry point for the AI to analyze that. And when a patient specimen runs through, it's that digital image file ultimately that's been scanned in our laboratory. And the AI is actually analyzing image features. So what we know is that the artificial intelligence tool has been trained to identify the visual patterns within the biopsy slide that are associated with outcomes, and so can figure out what looks like a bad feature that has worse outcomes. What looks like a feature that's associated with more benefit from hormone therapy, for example. What looks like a more favorable feature, and generates a model and a score output based on that. So what it's really driving is the visual features. Now, you asked the question of what is that the biology? Is that the DNA? Is that protein downstream? There's this classic saying that morphology is everything, right? So on some level, the downstream impact is these patterns that are visible on whole slide imaging.
I love it.
We've started to tell that story about what are the associations between the AI model, which has been developed, and sort of what it's paying attention to in the slide, and what are known DNA and RNA findings. And we do see that there is a strong biological story to tell with many of the features that have been identified by AI. And some of that work will be presented by some of our colleagues from the University of Maryland, so Food Trans Laboratory, at the upcoming ASTRO annual meeting. And it's quite a compelling scientific story where, as you'd expect, the higher risk Artera scores are associated with pathogenic mutations, and then the more favorable scores are associated with more favorable findings as well.
Okay. Anyone listening, I need to mentally pause for a second, because this is a completely new concept in 2 years of doing this. When I ask the question on molecular, in my narrow, ignorant 2024 thinking, I'm thinking about the only thing that I know, which is there are therapies for certain targets. So when I first heard about AI picking up on molecular features. It was on PET scans that a lung cancer, where I have to do the tissue thing and it takes forever and it can be insufficient. AI models I learned can predict that lung cancer is EGFR positive. EGFR makes you a candidate for a certain oral pill. And it blew my mind. I was like, wow, you can know a molecular feature based on just the analysis of how it's lighting up, right? And so I was thinking narrowly. I say narrowly now because Tim has edified me that the argument can be made, and I'm saying this and you're not, but y'all entertain the fact doesn't matter. Doesn't matter at the end of the day, like, because what you're saying, and bear with me because it's a weird analogy, but if you have dogs, in general, some dogs have better temperaments than others, right? Like, I love pit bulls, but some people might say they're more aggressive. Beagles howl. Like, pugs are just high maintenance because our first one was a female fawn pug, and that's what they are. But the point is, they all have different features. But at the end of the day, you can get all granular about it. But if a dog has the tail up and the fur standing and its teeth showing and it's standing up tall, regardless of the dog, that has a more aggressive nature and probably is not a good idea to reach down and pet, versus one that's wagging its tail and laying on the side. And if I understood it correctly, that's what your computer is saying. It's saying, we're going to look for every assessment on knowing longitudinally what ended up happening, that if that hand went down and it got bit, or the person didn't put the hand down, so used treatment, didn't use treatment, whatever that variable is, the behaviors are being learned that for whatever reason, showing teeth is bad and not petting is a favorable outcome, or not giving adjuvant, like is meaning like withholding is seemingly not any different than the other case. Is that correct? Where you're just regardless of trying to whittle it down, all you can, like the AI is saying, is we know that this thing that continuously we see, like it's a zebra and you see enough black and white stripes, it's not a horse. That just is what it is. It's learning those behaviors based on the actual picture it's assessing.
I think for the dog analogy, which is a great analogy, I think the AI, computer vision AI, would find the patterns such as how far away is the person's hand, are the teeth bared, is there a muzzle over the teeth, which might offset some of those negative factors. So I think you're right. Many of those factors are there. I was curious, you mentioned the EGFR example earlier in lung cancer, and I did want to come back to that point. What I talked about primarily for our prostate cancer test is pretty specific to prostate cancer, where there is precedent for treatment intensification decisions based primarily on Gleason score, which is architectural patterns which are associated with tumor grade. And so the Artera infrastructure and test development process has been successful at identifying prognostic groups, so which cancers are more aggressive and which patients may be okay to omit hormone therapy from. So it's basically a de-intensification tool. We have validated additional data that shows that in metastatic and in castrate refractory disease, our same test, our prognostic test, also predicts which patients benefit from treatment intensification, and on the other hand, who can be spared from treatment intensification. So we had an abstract at ASCO last year, for example, castrate refractory disease, that showed that the biopsy specimen from their patient's original diagnosis was associated with benefit from apalutamide as well for castrate refractory disease. And that's, we're trying to make a patient impact with our tools. So that's what we're about. We're very mission driven with providing oncologists and patients the tools they need. But when we go into lung cancer, breast cancer, other diseases where sometimes there are biomarker driven therapies as well, it is possible to apply computer vision AI to serve some of those same clinical needs. So, what we're really focused on is operating within standard of care therapy options that are generally, presented within national guidelines or, the rule book, as you referred to earlier, for what sort of treatment options are available. We want to better inform decisions there to make sure that we're providing optimal treatment recommendations for patients. So, we may expand into more diverse uses of computer vision AI as we expand it across solid tumors.
Yeah. And what I really respected, and I mentioned this a lot, and I love the statistics I saw, whether it was on your LinkedIn or somewhere, it's that we know about, I believe, 16 to 18% of African Americans, defined as African Americans, get prostate, cancer. Recently, same with, coincidentally, African American females. At first we were like, oh, their cancers are more aggressive, they don't respond as well. And then it's like little education. It's like, wait a second, we really based our therapies on a very underrepresented. If it's 20%, we didn't have 20% in the study. And obviously genetics are different because that's how we're kind of finding, at least on the outside, fortunately or unfortunately, the difference, but we're studying it on misrepresented, cohorts. And so you, at least for this, in the prostate capacity, y'all's analysis was intentionally accounting for that same distribution. If it's going to be general population diagnosis of race and ethnicity, et cetera, you wanted to mirror that in the kind of updated assessments that you all are doing. So I thought that was really cool. The thing that I want to ask, and I believe y'all consider this, but I'm not sure. One part of AI that I'm interested in, that I think we as just humans are far away from in medicine, is the effect of not just one drug, but what those multiple drugs that somebody's taking that aren't cancer treatments and how they may be actually influencing the outcome. So there's every now and then, well, if you're on a statin or metformin, you might actually have a better response, going to standard of care for this cancer treatment versus not, et cetera. I already answered my own question, because for the computer science learning, I'm sure that volume is diversified enough to where you're not happening to have everyone on a statin that happens to have this one feature. But you also have this AI in cancer therapy in general. Is that where you are considering possible relationships kind of deeper down, not just on the pharmacogenomics or the, size, weight, height, medical history, but even maybe the influence of other medications that are classically anti-neoplastic that may influence the outcome?
I mean, that's a really important area for further investigation. I mean, I guess I would frame what we're able to do right now and what we've done so far as, really we're committed to doing the best we can with the data sets that we have access to. We've been really fortunate. You touched on the importance of representativeness and making sure that your test is generalizable to the patient who's in front of you. And through our collaboration with NRG Oncology and our growing collaborations with other cooperative groups and institutions, we've been really lucky to get to work with really strong collaborators and develop tools that are validated in cohorts of patients that are representative of the U.S. population. And we're committed to doing even more of that. Along those lines, though, we can train our tools with the data that we have access to. We don't currently have a focus on developing tools that can account for multiple drug exposures, for example, non-cancer therapies. I think that's definitely an area where over time, artificial intelligence may be applied to. What I can tell you right now is that, we work primarily with clinical trial data sets, really? Which are wonderful to work with because you can be very confident of the quality of the clinical outcomes. So when you're developing your model, you can be certain that it's training in the right direction, and then you can have a high confidence in the validation data. And those clinical trial data sets most often do not capture sufficient data on the other drug exposures, but they're excellent data sources for really isolating the treatment effect of the experimental drug. And in that way, we work with hormone therapy and radiation therapy trials of prostate cancer, and that's how we're able to get so far.
No, I think that's huge. I'm currently developing a presentation. I had this primer of AI in oncology, and now I'm having the kind of 2.0 version, which is how do you vet? Okay, so you buy into it. What are some of the things that you're not even thinking about that could be potential pitfalls? And one of them is exactly what you said, is you have to know how clean the data is or adequately heterogeneous when you're uploading it. The fact that you said, that can't be understated, you're using clinical trials. I was like, aha, I didn't even think to ask that. But if you're a patient and you're going to do something like this, you're considering these options and you want to involve AI or whatever, or you're an administrator and considering it, that's so important because, to your point, even if it doesn't have everything by medication, it is just a cleaner set that is shouldering decades of extremely rigid, careful, cautious assessments to be able to have huge, like $billion consequences on what does work, doesn't work, and approved or not approved. And that's why I use that. That's a very cool thing that I somehow overlooked in my pre-reading. So I think that really puts a feather in the cap.
Yeah. I think you have to start with that. You have to start with good quality data, lots of it. And then we view publication and external sharing of results as a real imperative to make sure that the tools that we're developing are, well validated across multiple data sets, and that we've communicated what those data sets are to the physicians who'll be applying these tools in clinical practice. Because whenever you use a model, you need to know what it was trained on and what was validated on to really understand if it applies to your patients. It's the same thing with any clinical trial results. We're used to that in the clinic as physicians. But I think, we consider that a real imperative for us to get that message out there and make sure that we share. So we're constantly sharing results at national and international conferences and publishing as quickly as we can.
That's amazing. One of the things that I'm learning is after an AI model has been trained and tested and has their proxy metrics, et cetera, I could be wrong, but having the same way we define in a clinical trial, p-values, right? 0.05, confidence intervals. Like we have a very consistent way of defining statistical significance, et cetera, cutoffs, percentage of error. If I understand it correctly, the second phase, once a model has been at least tested and fed new data to make sure it's not overfitted and has good generalizability internally, with the validation process, what does that even look like? Because as I understand it, we don't even have it defined like, okay, this is good, this isn't, right? That's still being hammered out, if I understand correctly, because all of this is new. Is it mostly adhering to kind of similar things to clinical trials and saying like, hey, this is consistent, the same p-value and standard deviations, et cetera? Because that sounds like a really safe and clean way to validate for something that is still being defined.
Yeah, validation and being in following a pre-specified analysis plan is really important. So we work with, as I mentioned before, a lot of external collaborators, and generally our approach is to make sure that when we approach validation, we've got an agreed upon statistical analysis plan. The Artera platform is all machine learning. So when we talk about validation, we have a locked model. So once it's locked, it's unchanged. And so we are currently, offering commercially version 1.2, and so you can look at our publications for what version we're referring to in that publication. And then we continue to grow our independent external validation data set over time. We have an internal approach where the biostatistics team has total control, lock and key over our independent external validation data. And so the artificial intelligence team, when they're applying their machine learning methods to develop a model, does not even have access to that data set. And then we go through the validation process and either are looking at results concurrently with our external collaborators or, once they pass us the results. So, there are often a lot of times where we're waiting to see what those validation results are. But it's really important that we continue to do that. And so we're not only working with cooperative groups, but we are working with institutional data sets or, real world data, which is representative of patients that are treated in a variety of hospitals over time. And so we're committed to continuing to do that over time. It's really important to make sure that we've validated in a variety of different practice contexts. For example, one institution may use PET scans more than the other for staging, and that can change results, or these other little practice variations. And so we have to make sure that we've accounted for all that. And so we're constantly, focused on finding more and more collaborators and, testing our model performance on more data sets. To get to your point about how to report that, I think there are a variety of ways of looking at how a model performs. And so generally we're reporting on how the test predicts for benefit from therapy, or how the test sort of prioritizes or ranks sorts patients with a cancer diagnosis based on the aggressiveness of their cancer. So we're predicting when might the recurrences happen for patients from a clinical trial. And then we can have confidence that the tool that we built would do the same in clinical practice. And that's a little bit different from, is it a useful clinical tool? So that's where, we work closely with lots of physicians and have conversations all the time. I myself, part of my role in the company is to be that clinical voice and make sure that we're only devoting our AI science, biostatistics, and, clinical research time to tools that are really going to impact patient care.
See, and a lot of this may have been over the head or kind of a tune out from people, but I need to stress this. This is so important, not if, but when all of us are considering AI tools or wearables in our personal lives, in our professional lives, etc. This process you just told me, and I always have to say this because social media and all this stuff is whatever. It's not a sponsored thing. There's no payment thing here. This is an organic podcast. I'm proud of that. But what you just described is a very robust cleanliness of something to consider that someone may not realize the importance of considering. And I'll give you an example. And that's when I was on my nursing home rotation, which I thought I was going to hate, like on day one, which is awful, but I just, I was so focused on HEMOC. And it was an older attending, and he didn't speak much, but kind of in that first week or two, he kind of scoffed when somebody was walking by and said, hey, to somebody else. And I said, what's up? And he said, at the end of the day, he was like, you could have fancy nursing home centers. And they were all over the place. Some were like super clean, movie theater room, popcorn machines, like just like, things you see in movies. Others were far more homely and drab. And he said, you can make it look glitz and glam. You can show all these like cool areas, have good digital marketing, even the reviews. He's like, the thing that when you really vet, if you're looking for a family member, it's like, if I could leave you with one thing, when you walk in and the residents are walking by or through the halls, are the staff addressing them by name? Hey, like, Melinda, are you like, how's it going? How's your, he's like, that is the number one sign or reassurance that your family member is taken care of. And he's like, and you go into these fancy places with their glitz and glams and all their fancy tools, and you find that, they don't know each other. And like, oh, which room are you in? Whatever. That in itself, he says, is the biggest teller. That is, I think, something, which is why I'm making this new keynote or this new, lecture that I'm giving on AI stuff. Everyone's going to see the tools and the fanciness. We've had multiple AI companies, but I appreciate you going through that. And anyone that's listening, I appreciate your patience with it, because these are the things that ultimately do matter when things can look and appear fancy.
Yeah. And I think, it's interesting to talk to, we're two physicians sitting here talking about AI, right? But I think we should be in the discussion. And I think that's one of the great things about Artera is that we have this legacy where our two co-founders are an AI scientist and a physician. And, we are really focused on developing tools for, patient care. And I think that's different than, the classic model of a tech company with an engineer who's got a cool technology and is looking for a use for it. And that's one of the gratifying parts for this. So just for example, when we've got our prostate cancer test out there, and it's so gratifying to hear how it's helping people. I'm getting text messages from colleagues saying that they felt good about skipping hormone therapy for a patient and how appreciative they were. And with our internal development recently, we really focused on how we prioritize deploying our staff, because we have 100 people. It sounds like a lot, but we have a lot we're trying to do. And so we made the coordinated decision to really focus on informing active surveillance as our next, product update. So that's coming out in just a couple weeks, which is really exciting. And wasn't something that I, as a radiation oncologist, would have thought first to push for. It's not a pet project for me. But if you think about it from a global, and public health impact, for really giving people the tools they need to feel potentially more comfortable with recommending active surveillance for their patients, it really is the biggest impact that we can have. And so that's the sort of like permeated clinical insight that happens, in a group like this where we're doing, team science together, talking to docs all the time, hearing back from patients, and you end up arriving at these things where, we get to work with a lot of engineers and a lot of smart AI scientists, but everyone's kind of moving forward on improving clinical care, which is pretty exciting.
Yes, that's super exciting. And it kind of underscores the thing, sometimes shamefully the healthcare system gets very kind of, objective. And it's like, oh, the cancer's cured. And I've seen on social media, a lot of people feel truly like abandonment or like, okay, the thing's over. But then the whole cancer diagnosis and fear and side effects of chemo, none of that goes away. So you're at least trying to address and put attention into something that traditionally doesn't make, healthcare system or hospital money is to like this, but it gives peace of mind. And that's what that to me is what is really focusing on something that I just think all of this will really help patients get that community deserve what I think has been lacking, but truly evolving in a positive way. Now, because you're batting 100, I mean, not 100, 1.00, I'll give you a little bit of a difficult question. And I'd ended it on a slide on another talk that I gave about considerations. And I will say, and I'll disclaim, on everything you just said of the robustness on the validation and caution and abundant degree of caution and vetting, it makes me less concerned. But as AI comes out in a general, sense, and these machine learning conclusions, or let me put it this way, deep machine learning, like where it's actually like making conclusions and saying, hey, I know this says this, but really, this seems to be more favorable to defer, to go to second line, somewhat what you're doing at the adjuvant. When these outcomes come, that's where, just to consider, you now introduce the appreciable problem of deciding what is the clinical trial way that's taken forever and we know goes too slow and is approved, but then also what seems to a much higher degree of confidence just based on deep learning, which most every time you don't know where or how they came to the conclusion, but if it's validated, it is a conclusion. It puts two people at an ultimatum that's not at that moment, but in the future. And that means even if the outcome ended up being favorable or unfavorable, regardless of which one you chose, you're left with thinking, one, as a physician or provider, which one do I go with? Do I offer? There's some people that won't even offer the AI. I'm rigid and I'm sticking to clinical trials. That's going to be a disservice, conceivably, to some fraction of patients. That the data was there, that something different was the right thing to do, but you ignored it because we're going to figure that stuff out. The other part says, I'm always going to go with AI. It's probably not great either. And one is going to be between the two. And the moral injury that's incurred afterward, if it was unfavorable, even if you picked the best thing, is always wondering if you should have gone with the other guidelines until they update, right? This is going to hopefully not be an issue in 5 years or so. But then the other side is the patient, because the patient too now is going to be put in a position, unless it reflected quickly by a guideline, which I want to do everything I can and trying with ASCO and stuff to help facilitate, is the patient has to decide between the traditional doctor versus the doctor that's more open-minded and uses AI and considers their conclusions, versus the doctor in the same way this is, so do you want it or not? You're on the cusp. What do you want to do? The same way, it's like AI is saying this, these are the guidelines. They probably don't have enough experience to say, like, I feel okay with AI. It does introduce that thought. There's no answer. It's not really a question, I guess. But I'm sure it's something, with how comprehensive you all are, that you all have considered. And you're seemingly taking the one action you can, which is, let's just do everything on the planet that we can conceive that would give us the sleep at night to say we are very confident that if we made it available, if it was open market, that we've done every due diligence we could conceive between all of us to say this is probably correct.
That's a great question. And I think about many of these same issues. Like you, I probably like the doctor who's in the middle, who's not going to reject AI, but also is not going to blindly apply the results. What we really aim to do is help drive better decisions within the standard of care options. And so we always want to view the tests that we develop as informing clinical decisions, and they're not meant to be the sole basis to decide a clinical decision. So, we've talked before how it's medicine's an art and a science. There are many variables to consider. Sometimes patients, won't agree to standard of care therapy for very good reasons, and we end up, shaking their hand and saying, I think that was the right decision based on your rationale, right? And that they have other medical problems or other things. So, but getting back to how to use AI, I think you want that thoughtful doctor who's in the middle, who's going to get those results because they can be helpful. So it's a risk assessment tool that can certainly supplement the standard clinical considerations and help make that patient-specific optimal decision that everyone's overanalyzing, right, in clinic, and we're unsure of what to do. Do you want to go? Are we worried about the side effects of hormone therapy, or do we want to feel like we did everything possible? One of the ways that we've approached this at Artera is that we describe a two-step process. So for our prostate cancer test, for men with intermediate risk prostate cancer, we provide both an AI-driven risk grouping, which is a supplement in a risk score, which supplements clinical judgment or understanding of their prostate cancer on top of the other variables that are available for standard of care. And in addition to that prognostic information, we have a predictive insight that's provided about whether or not this patient is likely to benefit from hormone therapy. And we recommend that they're applied in a two-step process where you first think about prognosis. So if you have a patient whose cancer looks pretty risky, it's probably not someone that you'd want to think about de-intensifying therapy for. So just for that scenario you provided about you don't know the outcome is going to be, no one has a perfect crystal ball. We don't either. We have a tool that performs very well, and it's meant to help decisions. But if someone's at a higher than average risk of recurrence, even though if that predictive test says they may not benefit from hormone therapy, doctors and patients may see this in a different way. But if I'm talking to that patient in clinic, I actually might encourage them to go ahead and do the more intensive treatment regimen, just because you never know and you want to feel like you did everything possible within standard of care. That's one way to approach it. I think other people may see it differently. But in that process of first thinking about prognosis and then thinking about the predictive information, I think that kind of protects against, maybe over reliance on the AI tools, and really making sure that it's part of your medical approach and not a replacement for medical judgment.
I love that. And then you beautifully kind of walked us through the imagery of why physicians won't be replaced, in my opinion, because at the end of the day, you need a quarterback, really a teammate, and someone that's in your household, so to speak, that helps with all this stuff comes out, because there will be a traffic jam of just unbelievable stuff until it's streamlined. All of this will be a non-issue one, right? It will be standardized. It's not going to be a conflict. But there'll be people that will have cancer in that 3 to 5, maybe 7 year span when they don't align. And I think there is where physicians, can do really what I think is the most beautiful and fulfilling part of physician, which is guidance and care, and using your 13 years, because they don't have it, and not that they couldn't do it, but that's what you signed up for, to guide them to a decision, right? Instead of being reflexive, number one. Number two, I think is why it underscores the importance of what you had mentioned earlier. We are two doctors having an AI conversation, because I think it's responsible, because this conflict is ahead of us. Like, it's already here, but it's like the rain before the storm. It's here. And it's like, how are you going to guide someone if you don't have all the information? Right? Like it goes to basically practicing principles as well. And thirdly, it underscores both those things. Thirdly, what you're doing is exactly right. It's the same way that, Oncotype and Immoprint, not to use brand names or whatever, helped us kind of understand more on the adjuvant chemo for breast cancer. Like, it's like, yeah, you have like a couple of assessments, found problems, with both, with everything. There's always problems, humility and fallibility of the humankind, but they help. And so you're like, you have more tools. The thing that I see, one example is a patient that had a huge colon cancer, 8 centimeter. Okay. And so that 8 centimeters is enough to be now considered high risk. No lymph nodes, right? Well differentiated. But if I'm looking at the guidelines, it's like, it's really big, and they say like the increased probability because it's so big that maybe something just started off and mutated. But low grade, this, that, and the other, kind of this, age of 69, right? So you were worried about the tolerance. And I kind of went back and forth. I was like, we'll do circulating tumor DNA. I'm like, you're kind of on the cusp because you're node negative. It's well differentiated. All the other features are fine. No lymphovascularization. I mean, it was the most annoying situation. And then finally I asked the question. I'm like, look, at the end of the day, this may help. Are you the person? I'm like, there's 3 people. Are you the person that, if there's anything to be considered today that could make the chance of this coming back, or you living longer despite this diagnosis, a chance of making it better outcome? Are you the person that says full court press, anything that should be considered, with any kind of validation? I want to be the most comprehensive and aggressive, versus I want to weigh my risk and benefits. The person that I need a good reason. And somehow that just led to the thing, and this was earlier on in my career, where they were like, I'm the full court press person. Like, even though, ethnicity wise, there was like some reservation about chemotherapy, doctors, or whatever. I'm very sensitive to that. And I was probably being oversensitive, because when that question, I was disappointed myself. I'm like, I should have just asked that to begin with. My point being is that's where you can have that positioning that really can help you with the buckets and help you with the tools and decision making. But what's going to happen one day, really quickly, and I'm going to say this, and I'm going to get some unfollows and not unsubscribes from GI onc people. But I hate FLOT. It's never worked out for me. That is a combination regimen before, gastric, where you're like hoping to shrink it and get a favorable thing. It's toxic. I can imagine a day, but I still recommend it because it's the right thing to do. If they're fit, if they're like, it has the best chance. And, in my luck, I realize it's just anecdotal, 4 or 5 times the last year or two that I've given it just like hasn't had the outcome that was the best option on the shelf. When an AI says, bypass FLOT, consider doing GEM or whatever, FOLFOX and immune therapy or this other regimen, that wouldn't be the first guideline recommended based on the data. That's what I mean is where we kind of have to prepare ourselves and think, because now we have something that's saying that bypass the first because of XYZ, alpha, beta. But then me thinking forever, say it didn't respond to the second line, I always wonder, should I have gone to FLOT, even if it would have never responded to that either. But I live with that. And so does the patient, the spouse, and everyone else. I trust the doctor because he felt better. I can't totally remove my anecdotal experience. If you can't tell, I was a philosophy, studier like an undergrad. And these are the things that I think if we're not considering or prepared for, burnout, depression, strained relationships, and overwhelmment will happen very fast. And I'm afraid of how quickly. And that's why I appreciate you and what you all are doing. You're not just providing the tools, you're explaining the tools, proud of the tools. You're proud of even disclosing where potential fallibilities are in the measures you're taking. And it takes that transparent, lens, I think, to us know what we're doing without just 3 to 5 years of utter chaos.
Yeah. And I think, the example that you laid out, that hypothetical example of a large grade 1 tumor, some of your listeners, who are oncologists would know that for, grade 1 cancers, we typically think of more chemotherapy response in higher grade cancers, right? So there's this tension. It's a big tumor, but yet it's well differentiated. Maybe maybe the chemo is not necessary, or, isn't the first thing.
Behaves and it's pretty, yeah.
But one of the things that is exciting about a multimodal tool like ours, where we combine clinical information and pathology image-based information, is that we can pull a lot of those disparate risk factors together into a single composite score. So as a physician, we don't have a test for colorectal cancer, but if we did, if you were to extend that analogy, it would likely provide a score from 0 to 1, which, represented that patient's risk, as well as a probability of, say, recurrence at 5 years and whether that patient would benefit from therapy A or therapy B. So you're still going to have that conversation with the patient, and you're asking the same sort of questions that I ask my prostate cancer patients about, what kind of person are you? Do you want to have done everything? What's your risk tolerance, essentially? Or is quality of life more of a consideration? But at least I think from thinking about giving the physicians the tools they need to have the most efficient, satisfying, and effective conversation, if we can distill those disparate clinical and pathological variables into a single estimate, it at least alleviates a lot of the anxiety as a physician in the exam room, where your head is spinning with all these different factors. So we're trying to make that easier and to give people more, satisfaction with their decisions and less conflict around that. And that's the decisional outcomes and sort of how that decision felt is really important to us as well. I think that's a real important area where we can move the needle.
Yeah, I love that, because it's not always just the decision at the moment, but it's sometimes I think things we're not even aware of that we continue to labor over. Like I just brought up the 5 FLOT. Like clearly there's some, pain.
This is like a conversation you had today, right?
Right. And it wasn't. No, I mean, it has been in a while. It's just, well, maybe it was actually, but no, I can't say that. But it does also paint the lens. I'll just add on to that. Sometimes framing the question for patients and families, it sounds crazy and crazily simple, but I say like, okay, the other way to think about it, and I don't mean this to be, simplistic, I'll disclaim that. And I'll say, if this were to come back, God forbid, in 3 to 6 to 7, 9 months, the key is like when we've made the decision, right? Where I'm like, all I ask of you, you don't even have to answer it, but is if it came back, is the feeling or sentiment going to be, I know we should have just done the thing, or I know we should have elected for it, versus I know that was the right decision to defer. And I'm like, that's all that matters. Yeah. I'm like, that in itself is sometimes the best guiding principle. And the converse, if you have a toxicity, like are you going to say, I know I shouldn't have done it, but on the flip side, if it recurred, which one is it? I knew I should have done it. Then it's literally, sometimes you're picking between poisons, which is like an unfortunately, somewhat metaphorical term. Needed, necessary till we find better things. Tim, I could talk to you all day. You're dashing.
Likewise.
I was going to tell your team that the LinkedIn profile and the CMO company he's with does not do him justice if you're listening on Spotify or Apple and not able to see the video in real life form and only Google. But is there anything you want us to leave us with? Some sentiment you have about cancer? If you think it'll be cured, if you just want to leave someone with a message or nothing at all, I'm all ears.
I mean, I think that what really drives me and keeps me motivated is that, we're going to find more and more cures for cancer, and we're always going to have this struggle that you started off with highlighting, I think so well, which is that we want to optimize matching the right therapy to the right patient. And I think precision medicine, AI, like the stuff we're doing and other companies will be offering along the way, is going to really help us improve the art of science, where we can improve the overall population outcomes and how folks are doing in general in the fight against cancer, by making sure that we're not unnecessarily exposing people to toxicities for therapies that aren't going to benefit them, but we're also not losing an opportunity to introduce the right treatment at the right time. And I think we're going to overall improve outcomes. And then as we incorporate AI into practice, we're going to, as physicians, not the AI, going to be responsible for improving the art of medicine, which is using these tools and still having a really patient-centered conversation and hopefully have it at a higher level and with less anxiety and more certainty around it, so we can do a better job of helping our patients in clinic with old school non-AI medicine using these AI tools. So that's what I'm really excited.
I love that. And I will only piggyback that with, this all only happens if we are all willing for the greater good and humankind, human-wide learning, by sharing what our outcomes are, the kind of tumor types we have, who we are, what happened through our disease course or process, which is, believe it or not, the same way of saying sharing your data. But when I say sharing your data, I feel like people think I'm not sharing my social security number or address or, something. For the most part, if any of this makes sense to you and you're listening, these observations, these outcomes, these everything, in this case, it was, amassed from a trial, but they shared their data on the trial. The point is, when that conversation comes up, we can only make observations if we know what's happening. And that's where, one big thing I think we'll have to tackle. One, people insulate the data between institutions, between their pharma, they want their own conclusions the fastest. There's no question, I think you would agree, that if everyone just opened up clean data and we all had access, we would actually move the needle forward faster, right? But that's, again, fallibility, the biting of the apple, whatever you believe. One day I believe we'll overcome that, but I think all of us can kind of keep in mind that it is the greater good and what we can do together.
Well, thanks so much. It's been great to have the opportunity to chat with you, and thanks for being a champion for spreading education about oncology. And I couldn't agree with you more about, really having the opportunity to accelerate progress in cancer care with more data sharing and availability.